Welcome to today's OBSSR Directors Webinar. I'm Jane Simone. I'm the Director of the Office of Behavioral and Social Sciences Research here at the National Institutes of Health. Before I introduce today's speaker, I have a few housekeeping items. First, today's webinar is being recorded. This recording will be posted on our website in about a month. Today's presentation will be followed by a short Q&A session. To ask a question or a comment, use the Q&A button at the bottom of your Zoom screen. Feel free to ask questions at any time during the webinar, but we'll address them at the end. Please note that the chat feature is disabled and all attendees will be muted during the webinar. Following the presentation, OBSSR's Dr. Kathy Malsby will facilitate the Q&A and ask the questions you've written in to the presenter. And now I'm pleased to introduce today's speaker, Dr. Emily Wang. Dr. Wang is a professor at the Yale School of Medicine and directs the Center for Health and Justice, a collaboration between the Yale School of Medicine and Yale Law School. She leads the center's research program, which receives NIH funding to investigate how incarceration influences chronic health conditions and uses a participatory approach to study structural interventions, which mitigate the impacts of incarceration. As an internist, Dr. Wang has cared for thousands of individuals with a history of incarceration. She is the co-founder of the Transitions Clinic Network, a national consortium of community health centers dedicated to caring for individuals released from correctional facilities by employing community health workers with a history of incarceration. Dr. Wang serves on the board of the Committee on Law and Justice of the National Academies of Science, Engineering, and Medicine. She was inducted into the American Society of Clinical Investigation in 2021 and the National Academies of Medicine in 2023. In 2022, she was awarded a MacArthur Fellowship. Please join me then in warmly welcoming Dr. Wang.
Thank you so much. It's a real honor to be here today. And I'm really excited to share with you the work that our team and others have done. Last year marked the 50th anniversary of mass incarceration, a term used to describe legal and policy decisions that have led to massive expansion of incarceration as punishment and restriction on public social services, including food, employment, and housing for those with criminal records. By almost all accounts and among bipartisan leadership, it has been seen as ineffective in keeping families safe and reducing crime, much too costly, and has created widespread health harms. While there are a lot of questions about how to undo this harm, I'm certain of two things: that as physicians and as researchers, we've been complicit in creating the circumstances by which mass incarceration and its health effects are virtually invisible to us. And I'm also certain that we're responsible for finding solutions. And so for the next 50 minutes or so, I'd like for you to entertain with me how extraordinarily wide the reach of the criminal justice system is, how it impacts our work as scientists to create healthier communities, and hope at the end that you might consider how achieving health equity must necessarily attend to the criminal legal system and the ways that we might proceed. So today I'll start by sharing with you some of the epidemiology of mass incarceration, then talk about how incarceration impacts health and our healthcare system. Next, I'll talk about how we can bring science to study preventing and mitigating health impacts of mass incarceration, and then finally end with some concluding thoughts. The United States has incarcerated more people than any country in the world in modern history. In the past 5 decades, we've seen a quadrupling of the people who are incarcerated. And there are a number of reasons that explain this, including the criminalization of drug use, the deinstitutionalization of the care of people with mental illness, mandatory sentencing, and a legacy of structural racism, which continues to disproportionately police and sentence Black people and communities. So all told, there's currently around 7 million individuals who are under the jurisdiction of the criminal justice system at any given time. And that's approximately 1.9 individuals that are held behind bars in prisons and jails, and approximately 5 million who are being supervised in a large community system of supervision, either on parole, so those are folks that have served their time in prison and serving their sentences in the community, or probation. They have been convicted of a crime and largely serving their sentence in the community. We have at record now, it's almost 79 million adults have a criminal record. So it's highly common and prevalent in the United States. Those who are incarcerated are disproportionately poor men of color. In 2021, this is using life table measurements, it was estimated that 1 out of 10 men had a lifetime likelihood of being imprisoned. And when you break this down by racial categories, we find that 1 out of 20 white men have been imprisoned, as compared to 1 out of 5 Black men and 1 out of 8 Latino men had been incarcerated. Similarly, while incarceration is far less likely for women, Black women were more likely to be incarcerated in their lifetime compared with white women. In that same vein, Black families then are disproportionately impacted by incarceration. These data come from one of the only national studies that are really looked at kind of how family member incarceration has had a population effect. And to turn your attention to the rightmost bars, just to give an example, almost a quarter of Black Americans have 3 or more immediate family members. So that's grandparents, loved one, child, and spouse that has been incarcerated, compared with 5% of white Americans. So what does this mean for population health? It means that in certain communities, incarceration is norm, especially in communities with high percentages of Black families. Based on the work of sociologist Becky Pettit, the New York Times ran a headline that there are more than 1.5 million Black men who are missing from daily life between the ages of 25 to 54 because they're either dead or incarcerated. And this infographic from the article shows that in the yellow places, that Black men are missing, and the purple places are areas where they're overrepresented. And so while it's long been known that Black men are more likely to be locked up, more likely to die young, the scale of this combined toll is incredibly large. More than 1 out of 6 Black men aren't around in the prime of their lives to be parents, husbands, working citizens, and higher imprisonment accounts for about 600,000 of those individuals, and early death, 900,000. Homicide is the leading cause of death for young Black men, and heart disease for older Black men. And it's this missingness of Black men that has significant bearing for our understanding of the health of Black men, of health disparities, and our achievement of health equity. So I want to dig into this point a little bit more. If incarceration is an incredibly common experience among poor communities and Black communities, and a driver of premature death, we wanted to see if researchers were accounting for this in cardiovascular studies of health disparities. And we identified all studies funded by NHLBI who followed participants for 2 years and were interested in health disparities, and asked a pretty simple question: how many of them actually followed individuals, their participants that they had enrolled, into jails and prisons? And then how many studies among these studies asked about this very common exposure to incarceration in their studies? And it's probably not a surprise that none of these studies got IRB approval to follow people into jail, study participants into jail. And only one of these studies, Cardia, asked questions about exposure to jail. And so, sorry about that. We then wanted to find out how much of mass incarceration might be affecting a loss to follow-up, missingness not at random. And so calculated the loss to follow-up among certain demographic groups. And here I show a figure of the data for Black men, but we looked at Black men, white men, Black women, and white women. And then we estimated how much of the loss to follow-up might be due to incarceration, using data from the Bureau of Justice Administration that was specific to the demographic groups that were enrolled in the study, the timeframes, and the location of the recruitment. And so here in the figure, we show the data for Black men. In red, you can see the actual loss to follow-up in these studies over time. And in the blue, I'm showing the estimated loss to follow-up. And you can see that these are real prominent studies that many of you all will know: MESA, Jackson Hart Study, Cardia, and ERIC. And we found that anywhere from between 15 to 65% of the loss to follow-up in these studies among Black men was likely due to incarceration. And so this is a small study, but the point I'm trying to make is that the scale at which we've incarcerated in this country and have incarcerated in the last 5 decades has to be impacting our knowledge of racial health disparities, as most studies do not follow participants into jail and prison, do not include institutionalized participants, and do not even ask about exposure to incarceration. So now that I've given you an example of how incarceration is impacting our science, I want to shift the talk to how incarceration may impact individual health and our healthcare systems. And by doctors, I often get asked the question, why are patients that have a history of incarceration any different than other patients that I see? Aren't they just like patients who are poor, homeless, have a substance use disorder? And by researchers, I often get asked questions of causality. Is it really an independent risk factor? And, I've come to this place where I don't think we're ever really going to know, or never really satisfy critics, since randomizing individuals to incarceration is really an absurd proposition. But in the next few slides, what I want to give you is a look inside a prison healthcare system and try to convince you alone on face validity that exposure to incarceration, both being incarcerated and release, is a distinctly unique experience that impacts health, and then share with you some studies that we and others have done using observational data to build that argument. So these pictures all come from within San Quentin Prison, where I had a longitudinal primary care clinic as a patient, as a resident. And the media often will give the impression that those that are incarcerated are young and healthy. And the reality of it is that almost 80% of individuals who are incarcerated have a chronic health condition that warrants longitudinal primary care. So this includes physical health disorders like hypertension, diabetes, asthma. It also includes infectious diseases like hepatitis C, HIV, as well as substance use disorders and mental health disorders. And what initially drew me to this, and still is a place, that I think most healthcare providers don't actually know about this, is that healthcare is constitutionally guaranteed in carceral facilities. And it's one of the only places in the United States where there is this constitutional guarantee. And so what this means is that there's a large population of young adults that are likely accessing healthcare for the first time as adults behind bars. And in fact, our studies and others have shown that almost 40% of individuals are newly diagnosed with chronic health conditions behind bars. Just because there's a constitutional guarantee, though, doesn't mean that there's access to healthcare. And I'm sharing with you this picture for you to focus in on that pink slip. So that pink slip is a kite where individuals who are incarcerated have to fill out grievances or make requests when they have a health care issue or a complaint or concern. And in many settings, and not all, but many, it's a correctional officer that first evaluates whether or not there's medical necessity. And if the correctional officer thinks that there's medical necessity, then a nurse sees it. And then finally, you get to see a doctor. And you can see that access is limited by really unique institutional policies that just don't exist in the community. The other thing, perhaps that serves as an example here too, is that individuals who are incarcerated have to pay a copayment to see a healthcare provider. Here in Connecticut, where I practice, behind bars, my patients have to pay $3 to see a physician. And $3 may not sound like a lot to any of us, but $3 is equivalent to 4 days' pay. They make 75 cents an hour if you're lucky enough to have a job. And so you can see that there's really unique barriers that impact a person's ability to engage in health-promoting behaviors. This photo here comes from the daily rounds of a patient who's getting his blood pressure checked, who's just diagnosed with hypertension while behind bars and is coming back from the hospital. And these are kind of discharge rounds. And I want you to reflect on how much opportunity this patient has to have a confidential conversation with their healthcare provider about their elevated blood pressure. Each morning, the person is woken up at the crack of dawn by a correctional officer, makes the line, a nurse gives him his 3 new blood pressure medications. He takes it, given a cup of water. She checks to see if he's cheeked it, and then he moves back. to his cell. And so you can see in this example that adherence is almost 100%, but it's incredibly passive. Individuals behind bars don't have to think about when to take their medications, how to call the pharmacy, what diet, what exercise they would like to do. They have no control over. And so the experience of healthcare is really passive, and one for which they have very little control. The quality of healthcare behind bars is quite variable and largely unmeasured. And perhaps the best example of this is the delivery of care for people with opioid use disorder. Opioid use disorder is highly prevalent in correctional systems, given the criminalization of drug use. In a recent national study, it's estimated that about 40% of individuals who use heroin have spent time in a prison or jail in the past year. However, despite the efficacy of medications like methadone and buprenorphine for reducing death and also reducing future return to the carceral system, these medications are only available in some prisons and under certain circumstances, and even in fewer jails. And it's around less than 5% of facilities actually have access to all 3 FDA-approved medications for opioid use disorder. This is in part due to the fact that correctional systems security apparatus oversees healthcare. And so it's not physicians that are deciding whether and what medications are available, but security. And then I almost always end on this photo in particular. It's a photo of a patient, much like the gentleman that I started with, who has COPD, who's oxygen dependent, and is being held in solitary confinement. And solitary confinement is a form of punishment where individuals are held in 8 by 6 foot cells. And with the obvious implications of the photo is that you can see that his tank is held outside. And this patient, you could hear him banging on the door each and every time the tubing got kinked and he could no longer breathe. Again, the rationale being that the tank is too dangerous to be inside. But what's clear about this photo is that health is secondary to punishment, it's secondary to control, and secondary to safety. And you have to imagine that this patient, when they see healthcare providers like myself and others walking by, as being complicit in these health-harming behaviors. If you're the patient, how could you trust a health system that treats you in this way? And I think so what's important to remember is that this isn't just a behind the bars problem. Almost everyone that's incarcerated, and again, there's currently 1.9 million inside right now, are ultimately released. It's about 95% that are released home into the community. And given the carceral system and our criminal legal policies, among those that are released, in 3 years' time, 67% will go back in, and in 5 years' time, 75% will go back in. And so there's a huge throughput between these two healthcare systems. So what happens when a person comes home from incarceration? Well, to start, there's limited discharge planning. So individuals who are released really receive a short supply of medications, anywhere from 1 week to a month's worth of medications. They're released without their health records and released without a primary care appointment, largely. And so if you think about those individuals that are newly diagnosed with a chronic health condition, they have to come home, find a house, find a job, but then also find a primary care provider, find a mental health provider, and substance use treatment. In certain states, they're released without health insurance. They don't qualify in states that have not expanded Medicaid through the Affordable Care Act. And even if you live in a state where Medicaid has been expanded through the Affordable Care Act to this population, many states still terminate your Medicaid benefits and Medicare benefits. So there's a lapse and you have to reapply. And then lastly, I think it's important to note that these things are called collateral consequences, that once you've returned home, you've served your time, we have additional barriers to obtaining food stamps, WIC, Section 8 housing for people with criminal records in certain states. And so again, you've served your time, and then because you have a criminal record, and it's usually certain crimes, you can no longer meet health-related social needs. And so, not surprisingly, there's a high risk of dying immediately following release. This is a seminal study conducted by my friend and colleague, Dr. Ingrid Binswanger, that was published in the New England Journal of Medicine, that found among tens of thousands of people released from Washington State Prison, there's about a 12 times increased risk of dying in the first 2 weeks compared to demographically matched controls. And the common causes of death in her study were overdose, cardiovascular disease, community gun violence, suicide, and cancer, conditions that were highly preventable. And so the reality of it is that in spite of how healthcare is provided behind bars, it's returning back to the community that puts people at the highest risk. And we've seen this across conditions like HIV and cancer. And the question is why? And how do we prevent people from going in the first place or mitigate this risk? And so I'm going to take some time to dig into this using cardiovascular diseases as an example. That's been a focus of our work at the SAGE Center, both to illustrate the work that's been done, but also to show the limits of existing data and how we can design new studies to better understand incarceration's health effects. All right. So early on in my career, I was interested in studying whether or not incarceration independently puts individuals at risk for cardiovascular risk factors. And again, using the only data set that exists, Cardia, we took used data from Cardia, which has followed 5,000 young adults for the past 30 years. It's an incredible resource, and compared individuals at baseline who did and did not have a history of incarceration, and found that they had higher mean systolic blood pressure and a higher incidence of hypertension 5 years following baseline. And we found this even after accounting for their demographics, their traditional clinical risk factors like smoking, body mass index, drug use. And then additionally, because those who were incarcerated were mostly Black, male, and with limited education, we repeated these analyses in the subgroups as these were the sampling strata of Cardia, and showed that there were significant associations between incarceration and incident hypertension in adjusted models among all participants and these subgroups. We did not find these associations in populations where incarceration wasn't significant, wasn't common. And so you can see that the confidence intervals are quite wide. Also using data from Cardia, led by Dr. Coleman, we've looked at incident heart disease and stroke and found that, again, those with a history of incarceration in their early adulthood, especially among white people, had greater risks of being diagnosed with incident heart disease and stroke and dying from heart disease. We did not find this association among Black people, but this in part, as I mentioned earlier in the talk, I think is due to significant loss to follow-up among Black men, and we estimate that's due to incarceration, thus biasing these findings to the null. Where available, we've been able to use administrative data to also really explore these associations. And again, for this study, used Medicare fee-for-service data that was previously available and is now no longer available to study whether those recently released from correctional facilities have higher risk for hospitalizations and death immediately following release, and again, compared it to a matched comparator group. The top figure, figure A, are the time to first hospitalization, and figure B is time to death. The light blue is those never incarcerated, and the dark blue is those that were recently released. And as you can see here, those who are recently released from a correctional facility are more likely to be hospitalized, more likely to die following release. And in fact, 1 out of 12 are hospitalized within the first 90 days. And these hospitalizations, again, are readily preventable, and they include from conditions like hypertension and diabetes. So the underlying mechanisms behind these worse cardiovascular disease outcomes are likely multifactorial. And the NHLBI convened a workshop in 2016 where we discussed individual level effects of incarceration on cardiovascular disease outcomes. And as you can see here from this figure, while there are, of course, traditional risk factors that do augment risk, there are likely unique risk factors among individuals that have justice system involvement, both in prison and following release. And these include exposure to the prison healthcare system, exposure to the social context and physical environment behind bars, as well as limits on autonomy for health behaviors that drive accelerated development of CVD as cardiovascular disease, as well as poor cardiovascular disease outcomes. Following this workshop, we received NHLBI's first R1 focused exclusively on the cardiovascular health of this population, so named Justice. And we designed a prospective observational cohort of people recently released from correctional facilities who we are following for 12 months and examining changes in their cardiovascular risk factors like hypertension, diabetes, obesity, and hyperlipidemia, and really drilling into those specific risk factors that are unique to those that have justice involvement. So specific correctional policies, psychosocial stress, as well as self-efficacy. And a secondary aim of this study is then using the cardiovascular disease, excuse me, policy model to create estimates. Just take some water. I'm worried I'm going to start coughing again. Sorry about that. To model incident heart disease 10 years in the future. Sorry. And here are some of the data from those studies. Okay. So almost half of participants had an uncontrolled heart disease, cardiovascular disease risk factor at baseline. And in a paper that we recently published in the Journal of American Heart Association, we found that being in a jail as opposed to a prison, even after adjusting for, again, participant demographics and clinical risk factors, was associated with worse cardiovascular risk factor management at baseline. And we haven't finished 12-month follow-up yet, but we are finding higher rates of uncontrolled hypertension, higher systolic blood pressure, and higher levels of total cholesterol at 12 months, and as well as high rates of psychosocial stress associated with housing instability, food insecurity, and poverty. Sorry about this. All right, so as we continue to study the individual level effects of mass incarceration, there are clear next steps in this work. And one outstanding question is how incarceration affects cardiovascular health of family members who are left behind. There is a large social science literature that shows that having a family member incarcerated leads to decreased economic resources, reduced social support, housing instability, stress, and stigma. A few studies, and I'll highlight this one, that followed 1,800 women with women and found that women with incarcerated partners had higher rates of psychosocial stress, cortisol levels, and subclinical CVD. Further, our team has estimated using population estimates that family member incarceration is associated with an estimated 2.6-year reduction in life expectancy. Right. Another outstanding question is the biological mechanisms by which All right, the biological mechanisms of how mass incarceration might affect heart disease. And we hypothesized that in broad strokes, exposure to mass incarceration and to other carceral policies post-release, the social context and the physical environment and the healthcare system then leads to psychosocial stress, to trauma, both for individuals and family members. This then leads to behaviors and biological responses that then are associated with subclinical and cardiovascular disease. A place of recent inquiry, 2 new studies have found that there is a dose-dependent response with having been incarcerated and accelerated cellular aging, as demonstrated by epigenetic clocks. And so this is a place where we and others are really now trying to dig into what are the kind of cellular biological ways by which exposure to mass incarceration has affected health outcomes broadly, but especially heart disease. And lastly, there are new studies exploring the community level effects of mass incarceration on heart disease. On the left is a figure that demonstrates how much variability there is in jail incarceration rates by county, and this is produced by the Vera Institute. And 2 new studies are really taking advantage of that variability. One is a study in Atlanta that's using 2 existing cohort studies where they actually captured the zip code of residents and found that Black individuals living in neighborhoods with high incarceration rates, even after adjusting again for their clinical risk factors, their own demographics, and their own exposure to incarceration, were more likely to have hypertension, dyslipidemia, and metabolic syndrome. So again, these are folks, Black folks that are living in neighborhoods with high rates of incarceration, but haven't been incarcerated themselves. And then further, our group, and this work will be presented at the APHA, have found that living in counties with high rates of imprisonment is also associated with higher rates of stroke mortality, even after adjusting for % minority residents, socioeconomic status, and violent crime rate. And so where this leaves us then is that mass incarceration likely has effects on the individual, the family, as well as community level health, given its prevalence, and it has significant implications for population health. But our scientific infrastructure really isn't well established to study these effects or identify solutions to repair. And so as we continue to build out this science, we have really focused simultaneously on how it is that we can prevent and mitigate the health harms of mass incarceration. In 2020, I had the opportunity to start a new center at Yale, which is a partnership between the law school and medical school here, working to end mass incarceration and to identify the legal, policy, and practice levers that it can improve the health of communities impacted by mass incarceration. And at the core of our center are faculty, students, and staff who've been personally impacted by mass incarceration. And while our work, it covers many different domains, it's rooted in the delivery of primary care through Transitions Clinic Network. And so during residency almost 2 decades ago, I became obsessed with transitions of care for people that are returning home from carceral systems, and partnered with a co-resident and a large community of civil rights activists that had been incarcerated, trying to identify what we thought was going to be a simple solution to now what I'm learning is quite a big problem of transitioning care from carceral systems back into the community. But designed the Transitions Clinic program in partnership with them, principled on the beliefs that the best healthcare interventions are designed in partnership with those that actually are going to be using them and are tailored to their needs. And so at the core of this program is a community health worker. This is Mr. Jerry Smart, who has a history of incarceration, who's there in primary care clinic room, providing care alongside our physician, Dr. Lisa Puglisi, there in the picture. And the community health worker is essential both for helping an individual navigate the healthcare system, the social service system, but importantly, building trust in the healthcare system that's really abrogated responsibilities. And so under the leadership of Dr. Shira Shavit, we've grown this program into a network of programs now 48 across the country. We've provided primary care to more than 10,000 patients leaving correctional facilities, and have studied this when possible using randomized trials or pseudo-experimental studies showing that the TCM program improves engagement in primary care, reduces acute care use, and even reduces the return to carceral facilities. And now we're working closely with policymakers and community health centers across the country, especially as Medicaid is newly permitted to expand into carceral system, about how to implement this model program. And in so doing, we've been able to then, of course, build a platform for studying important research questions for our patient population. And so we have a study where we're evaluating the effect of the TCM program on opioid use disorder treatment outcomes that's funded by the National Institutes of Drug Abuse. And so it's this kind of partnership, the delivery of clinical care, that enables us to start building the science of how best to mitigate and improve health outcomes. When we first started, we had a lot of doubters. This is a photo of the first 14 community health workers who are the heart and backbone of our intervention. And we now have a network of almost 250 individuals with a history of incarceration that are working all over the country in community health centers, helping transition the care of people that are returning home from prisons and jails. And it's working alongside these individuals that's really transformed our research at Yale and our scientific norms. And it's including individuals that have been incarcerated that makes this work more urgent. It holds us accountable as scientists, and it flips the very questions that we're asking. So instead of asking the prevailing questions of what's wrong with these folks, what puts them at risk, we're asking kind of what's working in these communities and what sorts of structural supports are necessary for thriving. And we've slowly been building the knowledge base to do so. And I started at the beginning saying that, we have worked on cardiovascular disease, but now have NIH funding across some of the large causes of morbidity and mortality, overdoses I'd mentioned, and heart disease, but also gun violence, cancer, and COVID. And perhaps the best example of our partnership is this grant that's focused on gun violence. And I'll take kind of the remainder of my time just to touch on this briefly. Here is a picture of New Haven, and it's a picture of New Haven where, like many cities in the country, is beset with community gun violence. And the darker areas are neighborhoods where there's high rates of gun violence and a high prevalence of individuals who've been incarcerated. And almost 10 years ago, again, our community partners wanted us to dig into mitigating and preventing the health effects of gun violence, and specifically focused on what assets exist in the community. They were sick of interventions that were led by the police and led by the government, and they wanted interventions that tackled kind of the community context and the structural context in New Haven. And so at the core of this project then was finding and engaging a multi-stakeholder group where we could start talking very openly about different perspectives on the problems of gun violence in our community. At this table were police officers, the Board of Education and teachers, community residents, neighborhood leaders, people that had histories of incarceration, the warden of the local jail, in an exercise of group model building, gun owners and non-gun owners alike. And here started mapping out what are the various factors that affect exposure to gun violence, community gun violence in our community. The group was trained in systems thinking, so it's a holistic approach to analysis that really thinks about the system's whole parts, how they interrelate, and again, how different sectors of our community, different sectors of the government work over time in context of this larger system and problem, which is gun violence. The group was also, so that was one key component, And the group was also really focused on using local data and being transparent about the local data and using the local data in different ways. So Yale, we had the opportunity to work with these two sociologists who had previously been at Yale, Dr. George Wood and Dr. Andy Papachristos, who had used a social network analysis and spatial network analysis to really focus on understanding who are the victims and perpetrators and what blocks were more likely to have gun violence. And so what we did was took this data and asked, there are many individuals in the social network and many blocks that look like there should have been shootings and there have been none. What's going on with the individuals that have never been involved in gun violence and what's happening in these blocks? And so taking a positive deviance approach and interviewing those individuals and interviewing business owners or residents on the block. So using local data to tell a news story. And in those interviews, a number of themes came up. One is around home ownership and roots in the community. I think there's a lot of established families on the street. There's a lot of families with deep roots. They all know each other and they talk to each other, and there's a community. And then also themes of access and uptake of behavioral health programs. So it really kind of talking about the trauma that happens after a shooting. Well, usually I go to see a therapist and a psychiatrist and I talk with them about my problems and they help me deal with situations like that. And that's why they're there to help me, stay out of trouble. In the lack of understanding of the need for behavioral health, sometimes to attend to resultant trauma following gun violence. This is a picture of our causal loop diagram that we created in the group model building. And you can see that there were many components that overlapped with what came out in the qualitative interviews. And so after 10 years, it wasn't 10 years, but after 6 years, we then obtained a follow-up R1 where it's called True Haven. It's a neighborhood cluster randomized trial. And what we're testing is among people that are returning home from prison or their family member is incarcerated, whether providing financial literacy training and support for home loans and down payments, as well as providing kind of a community of mental health support in neighborhoods, whether these interventions at different levels affect exposure to community gun violence. This is a ongoing trial right now. But what I want to do is, with these two trials, show that we are now testing how community level or health system level interventions may prevent and mitigate the health harms of mass incarceration. And so in the last few minutes, I want to return to the question that I posed at the beginning, is whether achieving health equity can be possible without attending to mass incarceration. 50 years ago, we didn't have the level of imprisonment that we have in the United States, and the impacts of this social policy have had the largest bearing on Black families and poor communities, where health outcomes are the worst and persistent, and yet largely invisible to the scientific community and significantly understudied. And what's more is that there's really limited science to guide us on how we can prevent or undo this harm. And so here are certain thoughts that I have about how we may advance health equity. To start, to include people that have intimate experience of incarceration into the practice and governance of health research. And this includes those that have been directly impacted, been incarcerated, and their family members, as well as correctional officers alike. Within our center for the past 10 years, we've hired people with histories of incarceration as community health workers into the health system, as research assistants, analysts, faculty members of our scientific team, and have worked to change policies where they became a barrier. And are proud to say that after this work, we now have a Yale University-wide policy that was recently adopted as part of our Belonging Initiative, where hiring process is much more transparent and holds our systems accountable, where we actually have data on what happens when we hire people with criminal records. And, I'll be the first to say it hasn't been a piece of cake always to hire people with histories of incarceration into places like Yale. There are innumerable barriers to hiring people with criminal records. HR systems that don't recognize schooling or work history in prison, categorical barriers to employment in spite of even rave recommendation letters from the Commissioner of Corrections. But in hiring and supporting people that have been incarcerated really does take time and additional time and supports to guide individuals sometimes that haven't ever worked in the community or worked outside of prison back into the community. But universities and federal funding agencies like NIH, through their bold new initiatives like Unite, could incentivize hiring and supporting formerly incarcerated people. This practice, in my own experience, this practice of hiring people with histories of incarceration has really shaped Yale's institutional policies, identifying discriminatory ones where they exist, and also have changed our institution's culture. Second, we should prioritize research on how incarceration impacts health outcomes, and even more urgently, how to prevent it. And this includes, at the individual level, investigator asking about incarceration exposure in your ongoing studies, working with the criminal justice system to merge administrative data. This would also require including incarcerated people in national epidemiologic studies, and even the lessening of regulations on research of minimal risk in incarcerated populations. But it will probably require even more structured and systematic support. JCOIN, again, an effort of NIDA led by Dr. Tisha Wiley, is a perfect example of this. The team at NIDA has brought together hundreds of researchers, community practitioners, criminal justice experts, formerly incarcerated individuals, to design and implement scientific studies, share common findings, problem solve the challenges of doing research in jails and prisons, and also questioning the values and racism embedded within our science and institutions. More institutes at NIH could support other JCOINs, consortiums focused on disproportionately common conditions among justice-involved populations, and especially focused on preventing incarceration. And then lastly, NIH could consider including those impacted with mass incarceration as an NIH disparity population. They meet all 5 criteria of what constitutes a disparity population, but in particular, including those impacted by mass incarceration would enable an understanding of how a whole class of systems and structures and policies define health disparity. By naming it as such, I think it would engender a deeper focus on the questions we ask, the outsized and almost incomprehensible role that our criminal justice system has played in the health of our communities. And so I'm going to end, as I always do, with a picture of a patient. This is my patient, Mark, and he's sketched by permission, who was incarcerated for decades, whose joys are now his grandkids. I have now seen 3 generations of a family in my clinic, each affected by mass incarceration. And his and my ultimate interests are to understand how the mechanisms of how his past incarceration may have impacted grandchildren, and how we can best mitigate those risks to ensure they lead healthy and long lives. Mark reminds me and us daily that there's an urgency to this science now. We've gone through 50 years of this policy. And so I'm challenging you and us all to think about the connections between health inequities of our nation, our current criminal legal system, and how it may be compromising our hope for healthier communities. And so I'll stop here. I'm real sorry about the like cough spasm. I just could not stop it, but take questions, and really appreciate the opportunity to be here to share our work. Thank you.
Dr. Wang, thank you so much for what really was just an excellent presentation. We have received lots of questions from the audience. I probably will not be able to get through all of them, but I will share as many of the questions as I can. And to the audience, remember, please, you can continue to keep your questions coming using the Q&A function, and we'll get to as many as we can. So to start off, I wanted to ask, what do you think are the primary missed opportunities for investment in research for this area?
Yeah, I appreciate that question. It's something that I've spent a bit of time thinking about. So, to me, I think if I think about kind of the landscape of ending mass incarceration, really trying to explicate health harms, but also thinking about kind of what interventions we have to bring to bear, what investments in policies, what kind of social science needs to happen to really understand how it is that we bring our communities to healthier and whole. That there should be more investments, more work done, merging systems, thinking about intersectoral collaborations, and more research that looks at the intergenerational impacts of policies and programs as it impacts not only the individual that's been incarcerated, but their kids. And, you know, some of what I think is most interesting is, you know, now as an example, the moving on to opportunity studies, the best findings, like some of the best social science research that's happened in the 1970s, 80s, 90s, we're only seeing the kind of the amazing impacts that came to bear a generation later or 2 generations later. And the short cycles of NIH funding and all sorts of federal funding, it's like a 5-year grant and then it's done. But really kind of when we reap the rewards afterwards is, you know, maybe decades later. And so I'm deeply interested in how it is that we can think about the interventions that have impact now, but also for other generations. And especially, and the 2 examples that I gave, you know, there's all sorts of amazing interventions going all over within health systems, I see, within schools, within communities that are tackling kind of one said health outcome, but they have the opportunity to also look at, for instance, how this may decarcerate, how it is that those participants and their children and their grandchildren may be able to avoid the carceral system. And to me, these are the sorts of opportunities that we should really take a hold of now.
Thank you. It's really clear that meaningful, like very meaningful engagement with the community is critical and a key aspect to your work. So we have the question of how do you begin with building trust with members of this community? How would you suggest other researchers approach this?
Yeah, I think this is probably the linchpin, I'd say, for the work that we do. And to me, I mean, that's the place that you start, is building trust. You know, is if you are to enter with a research question that obsesses you, and there are many that obsess me, but if you enter in that space, that trust is lost. If, you know, I was a history of science major when I was younger, and you know, like much younger. And when you look at the history of science and the history of even modern science, but really the history of science in the United States, there's no doubt that, you know, if you were to turn to kind of a community member in New Haven, that history, that legacy of kind of the practice of science is one that's not lost on community members, and there's deep distrust. If you think about that picture that I showed you of, you know, how it is that think the physicians and then think about researchers, it's not a good look. And so to me, where we've really worked hard on is building kind of trustful relationships, asking questions that are ones that community members, they themselves, are driving, and then being really open to us being wrong. And I think that those are the spaces that we've been able to create, and now are really trying to push kind of our institutional policies to create more spaces, not for just at the SAGE Center, but how it is that, you know, it's 80 million people with a criminal record. Those folks, you know, all hands on deck. We're not living our best life right now. We need them to be working in our institutions. And so how it is that you can create kind of the structures within institutions to bring more community engagement, but bring people into kind of employment and jobs at places like Yale to improve our science, I think is a critical next place. And so we've worked to do that as we've done the science, and that also has engendered trust.
Thank you. So we have a few questions that are sort of specific to the transition clinic programs that you run. So the first is just about sustainability. Can you speak a little bit to sort of how you sustain that clinic program, particularly the financing component? And then as a follow-up question that I'll give you now, but I can give it again. And also if someone's interested in starting one or partnering with you on something like that, what would their best next step be?
Great. So I'll take that one first because it's the easiest, and I'll just clear that off, which is Dr. Sher Shabit, but the Transitions Clinic Network. You could just look online. That's the person to reach out to if you're interested in starting. Anna Steiner as well is our program manager, and you couldn't find more collaborative, thoughtful people to start thinking about how to guide you and your community and your team in thinking about building a transitions clinic program. The second question, I think, is a really interesting one and speaks to two things, which is one, that the crux of our program is a community health worker, which isn't funded in many states by state Medicaid, which is kind of the primary payer of care for people that have been released from carceral systems. They usually meet the federal poverty line. And again, in states where you've expanded the Affordable Care Act, still Medicaid doesn't pay for community health workers. And also in certain states, of course, where you haven't expanded Medicaid with the Affordable Care Act, it's harder to think about how you sustain programs. That said, what is happening is CMS, the Centers of Medicare and Medicaid Services, last year put out an announcement saying for the first time in Medicaid's history, they are enabling states to waive something called the Medicaid inmate exclusion policy, which prior to this, at Medicaid's creation, you could not use Medicaid or Medicare dollars to pay for the care of any institutionalized patient or beneficiary. And of course, Medicaid was founded in the 1960s, and now we've had 50 years of mass incarceration. And so the problem with that then is that there's really disjointed healthcare behind bars and then post-release. And so CMS seeing this, seeing kind of the high risks of dying, the high risks of hospitalizations following release, and again, we're in an opioid epidemic, have now created guidance so that states that are interested can submit something called an 1115 reentry waiver, whereby the state can apply to have Medicaid cover 90 days of care prior to release. And this opens up the opportunity for every state, but also transitions clinic programs, to start thinking about how billing looks. Can you bill for the transition of care? Can you bill for a community health worker following release?
Thank you. And I think we have time just for one last question. Can you please share thoughts on how to encourage early stage investigators to engage in this work? It is our experience that many shy away from this work, along with general violence work, given the IRB challenges that come with working with justice-involved populations, even if they are interested in this area and really recognize how critical and important it is.
That's a great question. And, you know, I would say there's a large and growing population of us that have explored this work. And sometimes I think it's, you know, is helpful to have mentorship among, you know, people that have kind of gone through the ropes and done it themselves. And so two places that I would turn your attention to is ACCJH. It's an amazing conference. This year run by Dr. Lauren Brinkley Rubenstein, and the next year Elise Wursel, but a community of health researchers that are focused on the carceral system, and many researchers attend this conference. And some of what I think is important is finding mentorship. Maybe it's not in your institution, but finding mentorship that's nationally and then can be supported by kind of institutional mentors is a really important way to design, let's say, a career development ward or moving forward, or even diversity supplements. So that would be my suggestion, is that the community of us is growing and larger, and you can find us at conferences. ACCJH is probably the easiest one that I've seen in my career.
Thank you. That's really helpful and informative. So now I will turn things back over to Dr. Simoni for closing remarks. Thank you.
Thank you very much, Dr. Malsby and Dr. Wang, for this talk. I really appreciate you taking the time to be with us here today. I want to remind everybody that a recording of today's presentation will be available on our website at OBSSR in about a month's time. And with that, I'll conclude today's webinar. I want to thank you, everyone, again. Thank you for attending, and everyone have a great day.